Good evening, friends. It's again Friday evening and one another session of basic classes. So instead of monotonously carrying with the ECG, I thought the basic topic of diabetic dyslipidemia, my understanding and how to manage it and how it is useful in everybody's practice. We'll see the next few hours how to do it. So this is a tailor-made approach for dyslipidemia management and Indian perspective. It is not, it's a predominantly Indian point of view approach. So I'm trying to get the guidelines from elsewhere and put it in practical use in India. So cardiovascular disease, as you know, is more common in diabetic patients than in the general population. Dyslipidemia, more common in both types of diabetes. Hyperglycemia is predominantly related to the microvascular complication and dyslipidemia, macrovascular complication. So it means diabetes dyslipidemia is a deadly for micro and macrovascular complication. LDL cholesterol is a known risk factor for cardiovascular disease. How this is going to affect here, we have to see. So we have to have a good aggressive lipid level management to correct this. So this is a good old slide, 2004. Multiple risk factors is known to cause coronary disease. You can see abdominal obesity, rather than we put it across insulin resistant state, diabetes, thereby diabetes, and diabetic dyslipidemia can result in 80% of the time a coronary disease. See here, 80% of the time, abdominal obesity, insulin resistance, diabetes, and dyslipidemia can result in 80% of the time. Multiple risk factors may be there, but these three can cause coronary disease very quickly. So predominantly the diabetic population, more than 50% of the people, close to 50% of people die with coronary disease. So that is a very, very high number. That means that we have to have a clear understanding of how to manage it. So the next statement I'm going to make is diabetes is equal to CAD equivalent. So it means having a diabetic population means already there is a coronary disease which has happened. That is the equivalent. So as I told you earlier, microvascular complications are more likely related to the hyperglycemia, and the macrovascular complications are more linked to insulin resistance, which starts well before the diagnosis of diabetes, and this can lead to more often coronary artery disease, rather than all vascular disease. Why is diabetes is equivalent to coronary disease? See here, 7-year incidence of myocardial infarction. If the patient doesn't have diabetes or MI, the chances of having a MI at the end of 7 years is only 3.5%. Statement is very clear. Whereas the patient has a no diabetes plus MI, it is a non-diabetic having an MI, within 7 years, the chance of having another MI is 19%. Whereas patient having diabetes, no MI, the chance of having diabetes is MI is 20%. Having diabetes and MI means 45% of the time, the second MI can happen within 7 years. This because the 19 and 20 are almost the same, we call it as diabetes is equal to coronary artery disease. Now you understand why diabetes is equal to coronary artery disease. This is the statement. 19% no diabetes, MI, 19% in 7 years. With diabetes, no MI, no previous MI, just diagnosed with diabetes, 7 years down the line, any diabetic patient, after 4 or 5 years, 7 years down the line, they are likely to have coronary disease in future. So we have to understand diabetes is equal to coronary disease. So for that, I told you the risk factors are abdominal obesity, diabetic dyslipidemia, and diabetes. This all. So these three are the villain which we have to address it. So for that, you have to understand the basic metabolism. Then you will automatically know it becomes easier. See here the lipoproteins. So this is the carrier protein of whatever the VLDL, HDL, LDL, and chylomicrons. The HDL carries predominantly the good cholesterol, takes back the cholesterol from the peripheral tissue into the circulation and gets it metabolized. Whereas the LDL carries the bad cholesterol, VLDL and chylomicron carries predominantly the triglycerides. So the first statement is very clear. HDL is good, LDL is bad. Triglycerides are carried by VLDL and chylomicrons. So the next statement I'm going to make. These are all statements which nobody can understand. It's a memorizable thing. HDL is the smallest of all. So it can get excreted through kidneys. Simple. HDL is the smallest of all. So it can get excreted through the kidneys. Whereas rest are all big, which will not get excreted through the kidneys. So it requires metabolism from the liver. So this is exogenous is what we eat, and endogenous is what is happening within the body. So whatever we eat, see here, whatever we eat, it can be absorbed as LDL receptor, by the LDL receptor as cholesterol. So that is the reason why you take a lot of carbohydrate, it will turn up into all the internal metabolism and go into acetyl-CoA pathway and can cause fatty acid generation and can result in, can go into the HMG-CoA pathway and can go into formation of cholesterol. So now we understand why exogenous pathway creates more cholesterols within the liver, right? So the endogenous pathway, see here, the liver secretes after its absorption VLDL, which I told you it's a triglyceride-rich particle. Then it is being acted upon by the peripheral tissue, lipoprotein lipase and hormone sensitive lipase, releases more free fatty acid. In normal circumstances, the free fatty acid can be utilized as an energy. And then it breaks down into IDL and LDL, and the LDL is again reabsorbed into the circulation. And it can be used for the peripheral tissues, which include the coronary artery disease, or coronary artery, or the carotid, or kidneys, everywhere it can get deposited. Now we understand the endogenous, exogenous. Now we will come to the diabetic dyslipidemia. So what happens when there is a insulin resistance? So very good slide, and this is the slide which everybody needs to understand. What happens to the insulin resistance after insulin resistance? So there is, you have to understand two things insulin does. There are two enzymes in the peripheral tissue which takes care of the fatty acid. One is hormone sensitive lipase, another is lipoprotein lipase. Hormone sensitive lipase depends on insulin. If there is more insulin is there, this is going to act on lipoprotein lipase and inhibit it. So it will utilize for energy. And also lipoprotein lipase is directly acted upon by the insulin. So this lipoprotein lipase and hormone sensitive lipase acts and produce lot of fat cells. Right? So this insulin resistance, as you know, causes hyperinsulinemic state in the body. So it means that it is going to inhibit hormone sensitive lipase, and thereby there is a inhibition of activate lot of hormones in lipase. Thereby it is going to inhibit lipoprotein lipase action, and this will cause more of free fatty acid. Accelerate lipoprotein lipase cause more of free fatty acid production in the circulation, right? So this increased free fatty acid because of the insulin resistance causes more havoc. This free fatty acid generally has to get stored in the body, adipose tissue, and it comes to the circulation. When it breaks down, it comes to the circulation, utilized by skeletal muscle, and the excess is coming back into the liver. This is what happens. So this coming back into the liver, because of the insulin resistant state, excess free fatty acid is being circulated, it comes to the circulation, and more it comes into the liver. Now you understand the endogenous metabolism of insulin resistance. This causing diabetic dyslipidemia. So insulin resistance, more free fatty acid, more coming into the liver, and this causes more production of VLDL. VLDL is a triglyceride-rich molecule, right? So what happens with VLDL? VLDL exchanges this cholesterol ester, cholesterol with HDL. So when the cholesterol is exchanged for triglyceride, see a triglyceride goes from VLDL into HDL and cholesterol comes out of it into the VLDL. And this HDL, once it is taken out, it becomes small. When it is becomes small, it gets excreted through the kidney. So first reason for low HDL is it becomes small density, and it gets excreted through the kidney. That is the reason why HDL is low in diabetic dyslipidemia. So lower HDL in diabetic dyslipidemia will cause, the cause of it is known, and this can prevent reverse cholesterol transport, which is going to be helpful to the patient. So it is not there means there is less HDL means straight away says that most of the people are having insulin resistance. Now you understand your mere lipid profile, low HDL, straight away says the patient has got insulin resistance. What next happens? It again exchanges cholesterol ester with LDL, and this LDL becomes smaller in density. This is what is called small dense LDL. So LDL numbers are not decreased, but it becomes small. The small dense LDL means this can break through the endothelial junction. This the skin, the endothelium has got small smell. The in between the cell, the large dense LDL cannot sneak into it to go into the subendothelial space, can cause a plaque. The small dense LDL goes into the subendothelium very quickly, and also this gets oxidized very quickly. So now you understand the diabetic dyslipidemia. One is insulin resistance, increased production of free fatty acid. This goes into the liver, produces more VLDL, which exchanges cholesterol with HDL. Cholesterol and triglycerides exchange happens, HDL becomes smaller, and this gets excreted to the kidney, and your kidney HDL, low HDL will cause more bad than good. And here LDL is exchanged, and this LDL will cause more small dense LDL, and the small dense LDL can cause more plaque. So more plaque production and low plaque rupture can happen, and the plaque cannot be cleared by the HDL because the numbers are less. So LDL number will not increase, but the small dense LDL for the same amount of LDL number will be more potent to cause atherogenic dyslipidemia. Now you understand the consequence of abnormal lipoprotein metabolism due to insulin resistance. Increased cholesterol, slightly increased LDL cholesterol, but massive increase in triglycerides and low HDL. So this is a combination with which we are going to work on, and this is what we have to understand. Indians have almost 80% of the people are having this type of dyslipidemic pattern. 80% of the people. So most of the time we are going to deal with this type of pattern. The triad of diabetic dyslipidemia is increased triglycerides, decreased HDL cholesterol. LDL cholesterol may be normal, apparently normal, but this small dense LDL cholesterol is very much increased, and this increase in the LDL cholesterol, small dense LDL cholesterol, can cause more atherogenic dyslipidemia and can cause more coronary artery disease. So 79% of Indians have at least one lipid abnormality, and predominantly is low HDL. So this low HDL, less than 40 in males and less than 50 in females, result in more coronary artery disease and stroke and kidney failure. So we have to be very, very careful in correcting this insulin resistance. So insulin resistance contribute to this characteristic dyslipidemia. So this is what called as atherosclerotic diabetic dyslipidemia. Actually, this dyslipidemia occurs much earlier than the diagnosis of diabetes itself, at least 3-4 years before that. So any patient with an increased triglyceride and low HDL, in a routine health checkup, you have to warn the patient that they are likely to develop diabetes in future. So they are likely to develop diabetes in 2 or 3 years. This is what the warning we have, and then we have to give the lifestyle modification. So ultimately, insulin resistance will result in hypertension, obesity, hyperinsulinemia, diabetes, hypertriglyceridemia, low HDL and small dense LDL, hypercoagulable state, and can cause atherosclerosis. Now you understand how diabetic dyslipidemia translates into more coronary artery disease. So what is the clinical clues of insulin resistance? Abdominal obesity is the primary, very good, straight away. That is the starting point of your insulin resistance. Increased triglycerides and low HDL cholesterol, glucose intolerance, hypertension, vessel wall thickening, and atherosclerosis, and predominantly Indians are more prone for it. So diabetic dyslipidemia is predominant in every part of the world. In Tamil Nadu, it is more than 10.4%, and pre-diabetes is 10.4%. In India, 85% of the time, prevalence of dyslipidemia in male type 2 is very, very high. In females, it is very, very almost 100% of the female diabetic population have dyslipidemia. So the total cholesterol appears similar, but LDL cholesterol is slightly lower compared to the Western population. But most of them are going to have small dense LDL, which is much more dangerous. Triglycerides are far higher, and we have a lower HDL cholesterol, the typical Indian cholesterol. So what happens to the smaller dense LDL? Once it goes into the subendothelial space, it actually goes through increased glycation and oxidation, and this resulting in more inflammation within the vessel wall, and can invite more of lipid core, forms more lipid core, and ruptures the core as well. And reduction of HDL prevents reverse transport of cholesterol in diabetes. So this is the reason why we are going to have diabetic dyslipidemia and thereby more increased coronary artery disease. So the quantitative wise, what are the numbers we are going to see? High triglycerides, reduced HDL cholesterol. Any lipid profile, these two are the hallmark. Total and LDL cholesterol are usually similar to non-diabetic, but only thing, it contains more of small dense LDL. How do you say it? I simply gave a calculation. Triglycerides by HDL more than 5, the ratio. So triglycerides is 200, HDL is 30, means it is more than 6.67. So if it is more than 5 means almost whatever you are going to see the LDL are all small dense LDL. It means it is a more potent LDL for the given number. A normal person with 100 LDL, triglyceride normal, nothing is going to happen. But the same thing, triglyceride high, low HDL and LDL 100 will cause more havoc and more coronary artery disease. That is because of the small density of LDL. So high levels of small dense LDL particles. So qualitatively, what are the things happening? The lipoprotein gets oxidized, glycated happens, oxidation within the vessel wall happens, and more foam cells and lipid blocks are formed within the vessel wall, and it can cause more coronary artery disease. So the three common factors which I keep changing: increased VLDL, triglycerides, decreased HDL because it becomes exchanges with the cholesterol, triglycerides, and becomes small, and the small density HDL gets excreted through the kidney, and the numbers are very less. Whereas the LDL becomes small dense, but still it is larger enough and it cannot go through the kidney. So the numbers will be the same, whereas HDL will decrease. So this is the reason why diabetic dyslipidemia happens. So to make it much more wider, all non-HDL, HDL is good. Non-HDL cholesterol are all dangerous. This is what the ultimate thing. So it means some are triglyceride rich and some are cholesterol rich. Cholesterol rich is LDL and HDL, is small dense LDL, whereas triglyceride rich is VLDL and in the intermediate density lipoprotein. So these are all the two things which we are measuring. VLDL, LDL are the one we measure. So total cholesterol minus HDL will give the number of non-HDL cholesterol. This non-HDL cholesterol combines both triglycerides, which is we are ignoring because we try to treat without knowing it, and Western people ignore it because there is not a problem there. And LDL combined together, cholesterol rich and triglyceride rich molecule. This is atherogenic dyslipidemia, atherogenic particles. So this atherogenic particle can be there, except HDL, all can cause, all are carried by B, apolipoprotein B, whereas HDL is carried by apolipoprotein A. So all when it is going to carried by all are becoming bad cholesterols, and this can cause more coronary disease. Now you are becoming more and more clear why we need to understand non-HDL cholesterol, which is a measure of both triglyceride-rich cholesterol as well as cholesterol-rich LDL. So both the cholesterols we have to understand, we have to do it. So triglyceride, which until now we have been ignoring triglycerides. So we have to understand triglyceride. But is there any treatment goal? We are not having goal, but where to start taking measures for controlling triglycerides, we know. See, triglycerides to begin with, it was less than 250. Now it is less than 150. So anything more than 150 is considered abnormal for triglycerides, right? So whenever you are going to have triglycerides less than 100, so predominantly when it is less than 100 means you are not having any small dense LDL at all. When it is more than 250 triglycerides means most of the LDL cholesterol which is present is only small dense LDL. Now you understand? Anything number, straight away, any number more than 250, most of the LDL cholesterol is small dense. Triglyceride by HDL ratio more than 5 means small dense, right? So that means that we are, the LDL number doesn't carry any value. Most of the time it is LDL. So even the 50 or 60 LDL is also going to be dangerous. So that is the reason why guidelines are making us to strictly follow statin therapy in management. So who are likely to have a very high risk to develop duration of diabetes more than 20 years in type 1, more than 10 years in type 2. So that's the reason why we keep on saying like a male age more than 50, female age more than 60, diabetes more than type 2 diabetes more than 10 years, primary prevention is required. Until then, statin is sufficient. Complications of diabetes, when it is there, it means that already the duration of diabetes is much larger. So this is the reason why, because triglycerides high and low HDL, saying in India, suggesting that the patient has got small dense LDL. So we have to have a strict LDL cholesterol target of less than 40 milligram for 50 milligram. So now you understand why the 50 was arrived. I always say, keep HDL at 50, LDL at 50, then it means that one is getting deposited, another is getting cleared. So it means that you are going to control LDL by strict diet and statin, so that keep the LDL at 50, your exercise and walking and weight reduction will increase your HDL to 50, and there is zero insulin resistance, and the patient is going to get benefit out of it. Right? So Lord and say, like, what are the intensity statin therapy? So even though there is a large list is there, we have got only 2 in our kitty. So rosuvastatin and atorvastatin. Rest all statins are not there in India predominantly for our practice. So only 2 statins, rosuvastatin, which is a water-soluble statin, and atorvastatin is a lipid-soluble statin. So there are reasons for mentioning this word, water-soluble, lipid-soluble. So other non-statin therapy, what is available? So bile acids, sequestrants are available. So these are all not used because it interferes with the absorption, and it is not going to be the first line of drug. So it is going to have abdominal belching, abdominal distension, belching, and all the side effects will be there. Fibric acid derivatives are there, which are not to be used on a regular basis. So everybody will claim that triglycerides, fibric acid are the best drug. But I'll tell you, it is not the best drug, because the fibric acid, by giving fibric acid, it is not going to decrease your morbidity and mortality. It is only going to decrease your number. Your lifestyle modification, control of risk factors, weight reduction, all these things are going to reduce your number, not your fibric acid derivatives. By combining with a statin, you are going to increase the side effect of statin and not your numbers. So I am against fibric acid. The carrying of message is very clear. Fibric acid should not be used for treatment of prevention of coronary artery disease. I'll tell you why. Other treatment, omega-3 fatty acid is there. It can lower triglyceride, but it is still require more evidence are there. STMP is there, it lowers LDL, but it doesn't decrease the mortality. PCSK9 inhibitors are there, it decreases the LDL to a greater extent, 90% reduction will be there. but comes with huge cost. Every alternate week 21,000. So that's going to be cost. So how do you manage this diabetic dyslipidemia? Simple. I'll use statin, diabetic dyslipidemia, patient is diabetes. When the LDL cholesterol is more than 190, that is familial cholesterolemia is there, straight away I will go for a statin. There is no question of having MI or having stroke or anything. LDL more than 190 and any given patient, start statin. 160 to 189, when there is going to be family history of atherosclerotic cardiovascular disease, then we have to start statin. The two places where statin, without diabetes, without anything, we got to start statin. So why we need to start statin much earlier? That is another question. So everybody comes, the diabetes comes with a lipid profile report to you. The lipid profile shows the LDL of 110, triglycerides of 250, HDL of 30, whether to start statin. The patient will ask, sir, LDL is only 100. Why do you want to start statin? I told, every statin, LDL here is small dense LDL, so start statin early. Why do you want to start statin early? See here, in days, it only LDL cholesterol is started low, its numbers are getting lowered in days. But endothelial function getting restored over months. Inflammation is reduced, that is prevention of rupture within the vessel was reduced after months and years. So ischemic benefits, mortality benefits are going to be there after years. Vulnerable plaque stabilization happens after 3 or 4 years. So cardiac event is going to reduce after 3 to 5 years. So it means that starting statin therapy today, tomorrow it is not going to reduce any coronary event. It takes 3 to 5 years to decrease a coronary event and mortality and morbidity. So it takes huge amount of time. So starting the patient with statin on the diagnosis of diabetes is essential. So the carry-on message is very clear. It requires 3 to 5 years. So now we know after diabetes 5 to 10 years, you are going to have a high risk. In 7 years, 18% to 20% of time, the patient can have an MI. So this is what the data is. So to prevent an MI, we have to start patient on statin. So every diabetic patient should be on statin unless LDL cholesterol is less than 40. So any number, 70, 80 LDL cholesterol, do not bother. Start statin. That is the carry-on message because it takes 3 to 5 years to decrease a cardiac event. The statin and risk of diabetes, another myth. It is very, 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 very small. So do not bother about the small number of increased tendency for diabetes. That could have been there with increasing age. So the patient has got a risk of coronary disease there means they are likely to have hypertension, diabetes. So they are likely to have stress. So they are likely to have diabetes. So do not attribute everything to statin. Statin doesn't have that much of potential to cause diabetes, and the benefits are far, 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 far superior. So do not deny a patient saying that there is a chance of having diabetes. Do not deny statin. Definitely you have to deny it. There is no question of lifestyle modification. So weight reduction, and first and foremost, weight reduction. Daily walking, prevent insulin resistance. Two things is sufficient. Replace rice with millets most of the time. You are through. Your diabetic dyslipidemia and diabetic treatment is through. So that's a way of going it. So lifestyle modification is very, very essential. So now, until now, we are targeting about statin, the cholesterol-rich non-HDL particle. The triglyceride-rich non-HDL particle is the one which is giving concerns, but we do not have a treatment. So we are not going to use fibric acid derivatives when the straight away for treatment. We are going to use fibric acid derivatives only when the triglyceride more than 100,000 to prevent pancreatitis, not to prevent a coronary disease. Please mind. Pancreatitis is prevented, not coronary disease. So we have to use fibric acid derivative only to prevent. So how to do it? See here, a mere weight loss will cause 20% reduction in triglycerides. Aerobic physical activity, 20%. Fish oil derivative, 20%. So these small things can cause significant decrease in triglycerides. So any triglyceride more than 150 to 490 address obesity, metabolic syndrome, correct the secondary factors like diabetes, CKD, nephrotic syndrome, chronic liver disease, hypothyroidism. So these are things should be there and not your fibric acid derivative. So please carry your message. Fibric acid derivative are not going to give mortality benefit. It is only going to increase the side effect profile of statin. Adult with moderate or severe hypertriglyceridemia, consider initiating statin therapy, not fibric acid derivative therapy. In spite of all the therapy, if you want to add something, means your triglycerides will cause small dense LDL. So to prevent that, add statin, not your fibric acid. So carry your message very clear. Adult with fasting triglyceride more than 1000, add fibrate therapy to prevent pancreatitis, not coronary artery disease. Right? So with this background, I'll go with case scenario and we'll see how to manage. So here, see here, 45 year, diabetes 5 years. It means one risk factor is there. Straight away, patient is going to have one risk factor. So it means total cholesterol is 170, normal, LDL is 110. So triglycerides, you will just look into triglycerides and HDL. Ratio 175 by 30, more than 5. 150 by 30 is 5. So more than 5, it is closer to 6. It means predominantly 85% of the LDL cholesterol is small dense LDL cholesterol. So straight away we know patient is at high risk of having coronary disease. So where do you stand? Type 2 diabetes less than 50 years with 5 years duration. So you come into moderate risk therapy. For primary prevention, we have data to say high intensity rosuvastatin is very, very useful. So primary prevention, high intensity rosuvastatin. So 40 milligram. Goal is to reach as low as possible 50 milligram. That's all. So from 110, it should reduce by 50%, 60% by giving rosuvastatin 40 milligram. So now how I started it? I just risk stratified the patient and I started rosuvastatin 40 milligram. So case number 2, 55-year-old male, post PTCA. Already a coronary disease has happened. It means target and damage has happened. He is not a diabetic. So here total cholesterol is 170. LDL is 90. So already post PTCA means already target and damage. Where is the LDL goal? 50. So it is high. Here again triglycerides and HDL is ratio is screwed. So it means in future the patient is likely to have diabetes shortly. Insulin resistance state is developing. And you are seeing target of 50 should be there. Now it is LDL is 90. So already patient on atorvastatin 80 milligram, full dose. Post PTCA, lipid soluble atorvastatin is being added correctly and full dose of atorvastatin is being there. Now it is not sufficient because we are not achieving the goal. So what to do? What is the LDL goal? LDL goal is after ANMI, it is high intensity, high risk patient. So we have to have a much more stricter control. LDL goal should be less than at least 70 milligram. So very high milligram, less than 50. So if it is not working, I may use for the reduction number STBB. So statin, it is not working. I can add 10 milligram STBB to a further reduction in cholesterol. Now you understand why I rarely use STBB, because most of the statin does the job for me. Very, very rarely I need to use it. So LDL after 6 weeks is 80. So we are not achieving the goal. We want at least, for me, it should actually 50. So LDL should be 50. What to do next? The patient is affordable. PCSK9 inhibitor every 2 weeks injection, and it costs you 21,000 per injection. So it is very, very costly, but 100% of time it is going to decrease your LDL cholesterol to 40 very quickly. So it is a very good medication, but only thing it is costly. So now you know how to achieve the target in post-PTCA. So next case is non-diabetic, only hypertension. Total cholesterol 200. Triglycerides is here. Triglycerides is 145. HDL is 30. It means the ratio is not more than 5, less than 5. So it means that more of normal density LDL is there. 120 is almost normal density. Non-diabetic, because risk is much lesser. No coronary disease, target disease risk is much lesser. So this is a low risk individual case. So low risk individual case means you have to risk stratify the patient with additional risk factor. As for diabetes, as for hypertension, as for family history, it is not their low risk, only lifestyle modification. Possible lifestyle modification. LDL goal here is only from 120, it is only 100. Lifestyle modification, 3 to 6 months. If it is not there, then start statin. Now you understand why every patient, non-diabetic patient, requires statin. So not necessary for statin. You can have lifestyle modification for non-diabetes. Diabetes, you have to necessarily start them on statin. Case 4, in coronary disease, post-PTCA, straight away high-risk patient. Straight away high-risk patient. On rosuvastatin, 40 milligram, highest dose of statin. Cough pain regularly. So this is disturbing to the patient. So two things. One is cough pain, other one is inability to get up from the bed without support. So proximal muscle weakness. So it straight away says possibly of statin myopathy. So why it is there? High dose of statin can cause statin myopathy. A small frame, small individual, 50, 60 kg individual can cause statin myopathy. Say grapefruit juice frequently, hypothyroidism, diabetes, all these things can increase your statin level and it can cause myopathy. Your alcohol consumption, heavy exercise, physical exercise can cause myopathy. So now you know what are the reasons for having myopathy in spite of the same dose. So when the patient has similar this type of illness, their modifications required, decrease the dose of statin. That is the only thing. Statin myopathy, pain, decrease the dose of statin by 50%. Once you reduce it by 50%, 90% of the time, your statin myopathy is clear. If I am using atorvastatin, I am reducing the statin from 80 milligram to 40 milligram. Still there is a pain. I want to continue only atorvastatin. I am reducing to 20 milligram. Still there is pain. What I will do, instead of a lipid soluble, I will go for a water soluble statin like rosuvastatin. So converting from a lipid soluble to water soluble can decrease your myopathy to a larger extent. Decrease the dose by half. If it is not working, change to another mode of the lipid or water soluble statin. That is going to be. Think of other causes: hypothyroidism, renal failure, physical activity, repeated consumption of grape juice. So all these things are there means you have to control it. Vitamin D deficiency, all these things you have to control. Once it is controlled, most of the time statin is a safest drug. So in my practice, I don't remember when I stopped a statin. Where nothing happens. Only thing I just give vitamin D substitution along with it. Most of the time patient becomes all right and no complaints at all. So statin associated muscle symptoms are rare. Even though 1 to 10% is given, for me it is much lesser. Myalgia, over a period of time, patient accepts it, and small learning, the teaching from my side is going to get clear it. So when the patient has persistently difficult myalgia is there, then I record creatine kinase. If it is more than 4 times the normal, then means I tend to stop the statin. Rhabdomyolysis can happen and decrease the sky. Here again, decrease the statin by 50%. If it is not working, another 50%, not working, change over to the other form of statin. Then most of the time, because your statin is required for plaque stabilization, decrease in HDL, LDL. If it is not working, then we have to change the statin. Now, management of statin myopathy, do not bother more than 4 times or 5 times creatine kinase. Do not bother about it. Vitamin D substitution, hypothyroidism, management of prevention, alcohol, all these things has to be taken care. And most of the time they are all right. If it is there, then we are free from it and continue with it. If it is not there, reduce the dose by 50% or change over to the other statin therapy, mode of therapy, either water soluble or lipid soluble. In spite of all these things happen, we have to stop it. So it is very, 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 very rarely you need to do it. Probably 1 in a year, something like that. So you need not bother about it. do not give them the buying impression of statin as a villain. So statin is a hero in every aspect. So statin has to be at any cost continued for the prevention of coronary disease and prevention of stroke as well. So vitamin deficiency should be ruled out, hypothyroidism ruled out, drug interaction, we need to look into it. Pitavastatin is another alternate of in statin myopathy, least myalgia. So instead of only concentrating on reduction of LDL, weight reduction, increasing nuts and exercise can increase HDL and prevent a coronary disease. So this is how we have to tackle statin myopathy. The next case is diabetes post PTCA. So LDL 55. Still, I am worried. I have to maintain LDL at that level. Triglycerides and HDL is ratio. Triglyceride more than 250 straight away says whatever LDL is all small dense. And the ratio is more than 5, all say smaller. On rosuvastatin 20 milligram, what next? See here, now I am recording the triglycerides. So instead, now I have achieved something. So 55, the numbers are close. So still I want residual, look into residual risk. So I'm just looking into the residual. The triglycerides more than 200 means less than LDL less than 70, you have a less, even in spite of less than 70, if the triglycerides is less than 200, you have got 13.5% mortality, whereas it is 20% if it is triglycerides more than 200. This patient has got triglycerides 250 and LDL is 50, 55. So less than 70 is their number LDL, but in spite of the less than 55, you are having residual risk. So triglycerides is the one. This is the where you are looking into triglycerides as a treatment methodology. Now you understand. You have achieved statin, achieved the target dose of statin 50-55 LDL. In spite of that, you want to have a look into the residual risk, where if the HDL triglyceride more than 200, you have to look into other methodology of treating triglycerides. Triglyceride treatment is predominantly secondary, weight reduction, control of diabetes, control of renal failure, all these things should be there, exercise, reduction of rice, everything should be there. So instead of that, in spite of that, it is not decreasing, means we have to look into treatment of triglycerides. How are you going to treat? I told you fibric acid derivatives are of no use. So we have to look into this ratio. See here, triglyceride HDL has got a very, very poor outcome. 3.31 odds ratio. That is very, very poor. Increasing HDL is going to help us out, but triglyceride and HDL go opposite. So we have to have further methodology treatment. So what drug we can use? So here, see here, there are some trials and data now to say that something is better than nothing. Icosapentaen ethyl, that is omega-3 fatty acid, is going to be of use. So this is going to be of use to some smaller excess here, 28% to 23%. So there is definitely a significant p-value. So only thing is you require to give a large dose, 2 milligram, maximum 4 milligram per day of icosapentaen ether. So this is going to give you reduction in triglyceride. It should not be used as a first line of drug after attaining the LDL goal with statin. In addition to lifestyle modification, triglycerides is high means you have to use icosapentaen ethyl 2 gram BD to get the triglycerides down. So now you have a carrying a message. Again, the next case scenario for post PTCA diabetes, LDL of 70. So I need LDL of 50. Atorvastatin 40 milligram, STMB 10, not affording PCSK9 drug. What next? So this then comes the bempedoic acid. So all our company person promote bempedoic acid as almost as replacement of statin. Never. It is not. Bempedoic acid is not going to give you the plaque stabilization. Nothing will be there. Mortal benefit is there only with the statin, not with your bempedoic acid. So very, very little mortal benefit is there. So residual risk is there. In spite of LDL 70, I want LDL of 50. So by increasing the statin, I'm not going to achieve it. So that I take the next step in the HMG-CoA pathways. So I take the mechanism of action, acyl CoA synthase pathway, bempedoic acid is going to act on it, and this will cause further reduction in LDL. And this is definitely over and above statin. It is going to be of use. Bempedoic acid, it is not statin, but it is not a placebo. It is going to act. It is going to prevent some mortality. It is going to prevent some bring in some plaque stability. Everything is going to be there, but it is not like statin. So it should never be replaced with statin. That is the carrying of message. But if all the therapy has been exhausted and you are having LDL of 70, then we can use bempedoic acid as an additional drug. So how I'll manage diabetic dyslipidemia? Simple. I'll pass the family history. I'll start screening the patient at 20 years after the college admission. Exclude other causes of dyslipidemia, primary dyslipidemia, to look into atherogenic dyslipidemia like a high triglyceride, low HDL. So atherosclerotic cardiovascular risk assessment should be frequently done in the young growing population to have a primary prevention. So stratify patient various risk categories. LDL goal cholesterol is the primary target. Rest all are secondary bonus targets. LDL level of 50 is safe. Do not worry about it. Do not patient tired out. Do not bother. Do not heed into it. Patient is going to live with it. So give additional add vitamin D and encourage them to take a lot of other nutrients or something like that. Do not stop statin. Non-HDL cholesterol, which contains both triglyceride cholesterol and rich cholesterol. So this should be the target. And it is whatever the total cholesterol minus HDL is the one. So non-statin drugs are less important in this dyslipidemia management. Even in India, it is not important. Even though we have high triglycerides, we are not going to concentrate on fibric acid. It is not going to help us out. No role of niacin. Role of omega-3 fatty acid is coming up. Lifestyle modification are very, very integral part of any management of dyslipidemia. You have to ensure that patient is going to have good lifestyle, weight reduction, practice primordial prevention, public awareness, very, very much essential. Is a major concern, and that is the topmost concern in India. LDL normal values doesn't carry anything. It requires a lot of introspection. The moment LDL is values are 70, 80, do not be happy. Look into triglycerides and HDL. Then you'll have the bomb coming in. Understanding small dense LDL is very, very important. So understanding the diabetic dyslipidemia is very, very important. Understanding insulin resistance and free fatty acid production, thereby increase VLDL, which exchanges with HDL and which makes it smaller and getting excreted through the kidney, and it reduces the HDL number, and the cholesterol, LDL cholesterol, always becomes small dense LDL, and this is going to be dangerous. Triglyceride reduction and HDL increase with non-pharmacological measures are the primary treatment. Statin remains the treatment of choice. And thanks for your attention. I stop with this, and you can ask your, I'll allow you to discuss. You can ask your question at any point of time.